Good evening, everyone, and welcome to Wu Yu, Restoring the Surface in Dry Eye Disease, Impact of Preservatives and Novel Formulations in First-Line Treatments with Dr. Selina McGee. Dr. McGee, thank you so much for joining us and for being with us tonight. We're excited to learn from you. And thank you to everyone for joining as well. I'm your host, Elise Kramer. So I will introduce our fabulous speaker tonight. Dr. Selina McGee is the visionary founder and owner of Bespoke Vision, a boutique private practice that offers patients a wide range of optometric care via its dry eye center, specialty contact lens clinic, and aesthetic suite. She is the first OD in the country to perform neurotoxin injections and laser resurfacing. She performs RF, IPL, and surgical lid procedures. She is a renowned national and international speaker. She is an adjunct assistant professor at the Northeastern State University College of Optometry. She currently serves as president for the Intrepid Eye Society, trustee on the SECO board, and the Board of Examiners in Oklahoma. She is a fellow of the American Academy of Optometry and a diplomate of the American Board of Optometry, and is past president of the Oklahoma Association of Optometric Physicians. Thank you so much again, Dr. McGee. We're super, super excited to have you. It is such an honor. And without further ado, I will let you take it away, and I'll be on later for questions.
Perfect. Thanks, Dr. Kramer, for the introduction. There is all of my financial disclosures, and it's an absolute privilege to be with you guys. I love to speak with you guys through Wu Yu, and she always has a fabulous lineup of speakers and also just the whole team. So you guys are in for a treat. All of my financial relationships have been mitigated throughout this. If you have any questions, like Elise said, make sure you put those in the Q&A. We'll get through those as we go, and then at the end as well. You can also email me. There's my email address, drmcgee@bespokevision.org. So tonight we are going to talk about restoring the ocular surface in dry eye disease and thinking about preservatives and the impact that they can have over the lifetime of our patients, why we choose the things that we do. And then we're going to talk at the end about the novel formulations and first-line treatments that are now available to us. And when we think about how we manage our patients, there's a lot to think about, not just what the patient needs at that exact moment in time. And so hopefully we'll walk away with this discussion with having, okay, yes, I'm going to treat the patient in this way today, but I'm also thinking about how that patient is going to look tomorrow and 5 years and 10 years and 15 years. Because preservatives, as we know, and eye drops can harm ocular tissues over time. And if it's the wrong preservative, it can take a very short amount of time. And when we think about even what patients are using around their eyes with preservatives, that can also complicate matters and cause some comorbidities. So when we switch to preservative-free options, that can help us with eye health and compliance and managing the ocular surface for that patient's lifetime. So that's kind of our setup and how we're going to go through things. But I think it's important to think about preservatives as a whole and why we're talking about this, because essentially our patients come in to see you and I because they want to have good vision, right? They're there for the best vision possible. And the drops that they use over the counter that they're choosing are important. And they don't always realize the impact of what that means and what that can do to their long-term ocular health. And so I think it's really important for us to have those conversations. And then when we think about conditions that disrupt tear film, whether it's they truly have dry eye disease, whether they have ocular surface disease and something else going on like conjunctival chalasis or epithelial basement membrane disease, blepharitis, and then of course preservatives specifically around glaucoma, I think is the one that really can cause long-term problems. So we're going to talk about that. Innovative approaches to restore the ocular surface. So there's multiple ways now for us to think about how we manage the ocular surface. And we have some preservative-free options. We have ocular sparing therapies, and we have interventional dry eye therapies. And so those are some terminologies that you are familiar with, but there may be a few there that you're not as familiar with. So thinking about that in a different way and kind of what that really means for our patients and for our clinics. And then our treatments and management strategies, of course, are going to be aimed towards restoring the ocular surface and enhancing visual function, because it goes right back to what our patients are desiring in the fact that they want to see their very best. And to see their very best, they have to have a healthy ocular surface. and a healthy tear film. So when we think about the overview of dry eye disease, we know it's multifactorial. There's multiple things that happen that can cause us to lose homeostasis. And when that happens, we have tear film disruption. Now we have hyperosmolarity. Hyperosmolarity means that we're going to have light scatter. When we have light scatter, we're not going to have good visual quality. Then we're going to move into having cell death because we've got hyperosmolar state. From cell death, now we're going to have inflammation. When we have inflammation, it's going to recruit more inflammation in the way that T cells recruit in dry eye disease. And now we've entered that vicious cycle that we've all heard so much about. So all of those things highly impact our patients' quality of life. And that's why I'm so passionate about dry eye disease. And I had such an impression as a young optometrist with patients that had mild, moderate, severe dry eye, and why I care so much about patients because of how it affects their day-to-day life. When we think about the role of preservatives, we need preservatives if we have a drop that's going to be in a bottle that's water-based, because we've seen the repercussions of not having that, right? We get horrible microbial infections, horrible fungal infections. And so there is a role for preservatives, but thinking about how to manage that and looking at options where we have preservative-free bottles, preservative-free vials, single-use doses, therapeutics that don't require a preservative, all of those things we should be thinking about. And especially long-term use, we're going to talk quite a bit about BAK, because this was the first preservative and certainly still the most common, but it has some really to the detriment of our ocular health, and long-term can really exacerbate ocular surface disease. And when we think about the patient impact, especially in a glaucoma patient who's on sometimes a drop for the rest of their life, oftentimes with BAK, when you look at compliance rates on the patient who also has dry eye disease, and in fact, the drop that's helping them not go blind from glaucoma is causing their dry eye, they're going to be less likely to be compliant. And we have studies that support that because of the way that their eyes feel. They don't put their drops in. And so that's the other challenge in all of this. And so it's just crucial for us to think about the patient from not only what they need today, but what they're going to need tomorrow and how that's going to impact their life for the next however many years they have and have to have and want to have high quality vision that doesn't fluctuate throughout the day. So when we look at dry eye disease epidemiology, the prevalence continues to go up because our demands continue to go up. You know, when I first started practicing, we didn't really talk about screen time, but now I specifically ask not only how many hours are you on a screen, but I need to know what kinds of screens. And on average, my patients are looking at 3 screens at once at work. So we've got 3 screens we're working between. They go home and they have a laptop in their lap, and then they have a phone in their hand. So we have to be specific about how we ask about screen time, because if you just say, how long are you looking at a computer screen, that doesn't give you the whole story. And so when you look at the prevalence rates affecting between 5% to 34% of individuals over the age of 50, that to me is really low. What we do know is there's a rise and there's an increase in prevalence, and there's certainly an increase in prevalence in younger and younger and younger patients. I have 12 and 13-year-olds who have lost 3/4 of their meibomian glands, and because of extensive digital screen use. So that's important for us to talk about when we think about implementing and having a visual hygiene system for our patients. You know, here's best practices. You got to take a break. You need to spend time outside. It's not only the blink reduction, it's the fact that your blinks aren't as complete. So it's the type of blink that goes down as well. So when we look at prevalence, it's just going to continue to go up. When you look at, you know, stereotypes, it's always been the 40-year-old perimenopausal female. And while we have more birthdays, and once you get over the age of 40, it does become more female dominant as far as who has more severe dry eye. And when you look at patients under the age of 40, it's equal actually between males and females. And so that's important too for us. And I say all of that because I think it's really paramount that we are intentional about looking for, talking about, asking our patients symptoms of dry eye disease, because I have the mindset of this patient has dry eye until they prove that they don't, just like we do with glaucoma. Every patient that we walk into the room with, we prove that that patient doesn't have glaucoma. How do we do that? We check IOP. We look at the optic nerve. We check visual fields. And what all of those things go into, okay, this patient is good for another year. They don't have glaucoma at this time. Are you as intentional about looking for your dry eye patients in the same consistent way? And that mindset shift is so important, and it doesn't have to be hard. It can be a questionnaire. We utilize a speed questionnaire in our office. Every patient fills that out. And we do vital dye on everybody, looking at tear film, looking at non-invasive tear breakup time. You can look at invasive tear breakup time with sodium fluorescein, and then looking at tear meniscus height. All of those things with vital dye are critical to diagnosing. And then the last thing that we have to do is push on glands, so we know how the patient's meibomian glands are functioning. Those three things, you are going to be able to diagnose all of these, undiagnosed patients that are going through our chairs and suffering long-term because we missed their ocular surface disease last year, the year before, 3 years ago. On average, and this is not on here, but on average, a dry eye patient will see 3 providers and has been on 3 different over-the-counter medications before they ever get diagnosed. So there's so much opportunity here for us, and it affects every part of our practice. So no matter what specialty you have, whether it is you are the best person to get a refraction from, whether you have specialty contact lenses, whether you're doing just lots of contact lenses, if you're in aesthetics, dry eye, glaucoma, pre-op, post-op, cataract, whatever it is you're doing that you specialize in, dry eye affects every piece of it. And it's going to limit your success and limit your patients. So when we think about dry eye disease, this is a common and debilitating condition. It significantly impacts quality of life. When you are thinking about your eyes 24 hours a day, and I had a patient actually yesterday, and he's been suffering for 5 years. He'd been to 6 doctors before we diagnosed him with what he had going on. I'll share more with that later. But he's like, I cannot leave the house not knowing that I have my drops with me, because if I get somewhere and I don't have them, it's a recipe for disaster. So that certainly impacts quality of life. And we have chronic symptoms. This is a chronic progressive disease that we're managing. And I think that's really important to set patients up for success, so that they understand that there's no cure, that you and I are going to manage it together. Impact on their daily activities. How many patients have you ever had that, they want to read and they're like, I sit down to read and I can see for 2 pages and then everything goes blurry. I mean, how frustrating. The productivity at work. Kelly Nichols did a great paper and a study a few years back on productivity and looking at absenteeism and how dry eye disease affects both of those. The emotional impact, it is linked to depression and anxiety. And then we have these changing risk factors because of the rise in digital screen use. Our visual demands are just the highest they've ever been. There's huge opportunity there to help our patients. So back to preservatives, when we look at BAK, how long has this been around? This was the first used as a germicide in 1910. And then it really started in the 1940s in eye care as a very effective preservative, and it is. But it's toxic to the ocular surface even at really low doses. And so this is just important for us to know. And when we think about how we're managing patients long term. So, preserved versus non-preserved topicals, there's other preservatives in eye care. There's a few listed there. Different mechanisms of action. Each alternative has a little bit unique way. And then looking at, are there opportunities for us to utilize a preservative-free choice when we can? And the drawbacks and downsides of preservatives, again, they exacerbate ocular surface damage, worsen symptoms, limited effectiveness for complex and multifactorial dry eye disease. And then we have, continued widespread use of BAK, and, lots of things that are over the counter have BAK that patients are unknowingly utilizing sometimes multiple times a day, that if we don't ask good questions, we won't know. And so it can really sabotage your best efforts. When you look at BAK, what is it? What are the complications that can happen? What's happening with it? And that exposure on the ocular surface, it causes swelling and desquamation of the superficial corneal epithelial cells. It will infiltrate and cause inflammatory cells in the conj. It decreases goblet cells, which we know are very specific, and we need that for mucin production. We get reduced corneal nerve fiber density. If your cornea no longer can talk to the brain and tell it what it needs to do, when you have that reduction in corneal sensitivity, now you have a neurotrophic cornea that no longer functions properly, and the whole system starts to break down. And that, leads us down the path of suggestions of corneal hypoesthesia, and remembering that we absolutely, in cases where we see things like staining and the patient's not really having any symptoms, that we need to be doing corneal sensitivity testing. It's a simple, very straightforward test to just measure how the patient has sensation. And remember, when you're doing corneal sensitivity testing, there's a couple of ways you can do it. You can do it with dental floss. You can do it with a little corneal wisp. But I like to test 5 quadrants. So I test at 6 o'clock, at 9 o'clock, at 12 o'clock, at 3 o'clock, and then central last. Because the corneal raphe, you can have different areas of sensation. And so I think that's really important on those patients when you're like, this doesn't make sense. Something else is amiss here. So don't forget your corneal sensitivity testing. When you look at in vitro studies looking at the damaging effects of BAK, it has that reduction in the viability, again, of epithelial conj cells, and then that increase in activation of inflammation. So all of this to say that we have options and we need to think through them. When you look at all of the studies, again, this is just reiterating that point, that this is all backed in good science, and we're utilizing a preservative, again, that started in 1940. There's lots of other common ingredients and tear substitutes, and this is what patients are typically utilizing over the counter, other than, a redness reducing drop that they want to utilize in a way that we don't want them to, right? Because typically it's got a vasoconstrictor in it. Now we're going to have rebound effects. There's preservatives in it because it is in a bottle. So it's important that we know what patients are utilizing, and then it's important and crucial for us to give patients options when they need something to help support that front surface. And so there's lots going on here, and there's lots of different drops that we can choose. Preservative-free is high, of course, on my list. You have, options, and typically you're going to look for hyaluronic acid. You're going to look for osmoprotectant. Things like trehalose is really good. It prevents epithelial cell apoptosis. Looking for like oily agents that will stay on the front surface. And remember, a lubricating drop is only going to stay there for probably 2 to 5 minutes, but with different things on the front surface that can help us support the front surface. The big key takeaway here is making sure that you know what's in it, what the patient is utilizing, how often they're utilizing it. All key things that you can help with the best outcomes. So when we think about what we want for our patients, when we're looking at, okay, how do we treat ocular surface disease? How do we treat a patient that has comorbidities? We have to thoroughly assess the ocular surface health. We have to truly understand, does this patient have dry eye, or is it something else? Which is why your questionnaire, why your vital dye, and why pushing on glands is so important on every single patient, because that's going to give you all of that information in a short, very specific kind of way. When you're looking at tear replacement therapies, make sure they're preservative free, you're supporting that front surface, and then we can individualize treatment. And that's what we're going to talk about here in a little bit, because now we have a lot of first line therapies that are very targeted in different ways, which is exciting for managing these patients in a multifactorial disease. And now we have multifactorial ways to treat it. So when we look at, patients that come into our clinics, we need to ask the question, are you utilizing a drop over the counter, or do you feel like you need to? Have you ever used anything over the counter? And they say yes. The next question should be, do they help? Because when they say, you know what, they seem to help for a little bit, but the problem seems to come right back. That's a big red flag that we have more going on, and we need something beyond the lubricating drop that's trying to help support the front surface. It just can't do all the things. And so that is a big question, I think, that's really easy to incorporate. Are you utilizing anything over the counter? Do you feel like you need to? And do they help? And then we're going to, educate patients around that, because often, again, the things they use over the counter are not things that we want them to use. When we look at all of these new formulations, we have ocular sparing formulations, we have drops that don't even contain water, that are 100% preservative free. So we can think about all of these, and the carrier molecule is just as important as what's going into the medication. So we have to look at the whole formulation when we're looking at new therapeutics. We talked about trehalose and hyaluronic acid. Those are two of my big ones that I look for in a lubricating drop that's helping support the front surface. And again, we're looking at dry eye disease signs and symptoms. And when we think about preservative-free formulations, it's not just lubricating drops, it's glaucoma drops, it's dry eye therapies, it's anything you're putting on the front surface. And so when do we switch patients? Well, when we have a patient, especially a glaucoma patient, depending on how many birthdays they have, the rate of their disease, we need to think about, okay, do I want to put this patient on a drop for the rest of their life? Because we know 60% of our patients that wind up on a glaucoma drop are going to have ocular surface disease. If you have a glaucoma clinic, you inadvertently have a dry eye clinic. And thinking about that for that patient, again, when we're sitting in front of a glaucoma patient, we're like, okay, I want to get the pressure down. Here's my range. Here's what's happening with the patient. And I want to get the IOP between 12 and 15 or whatever it is for that patient on the range. Sometimes we can get so hyper-focused on that we don't think about the broader piece of, okay, what's happening on the ocular surface? Is the patient going to be able to take this medication? Am I going to cause a problem somewhere else? Do I have options to manage this patient just as effectively that will work out better long-term for the patient? Because we do have preservative-free options, whether it's in a bottle that's multi-dose, whether it's single-use vials. We have some specialized ways to manage that now. So how do we match these specific targeted therapies on the front surface? And we need to understand what's really happening on the front surface. So that's why it's so important, I believe, to have some kind of questionnaire, and you can ask the questions yourself. I mean, there's 3 simple questions you can ask, whatever works in your clinic flow to get that information to every single patient every single time in a consistent way. And then looking again at vital dye, I'm looking at tear breakup time, I'm looking at tear meniscus height. So I can tell if the patient doesn't make enough tears, they make too many tears, and we have a drainage problem either because of what's happening with the puncta, or we have an issue like conjunctival cheilitis, and we have issues where it's not able to flow into the puncta properly, or we have tear meniscus that's just right. And when you look at enough of those, you'll know when it's too high, too low. You don't need specific tools to measure that. And then looking again at meibomian gland function so that we can see, do we have non-obvious meibomian gland function, dysfunction? Because when we're pushing on glands and nothing's happening, that's a non-obvious meibomian gland dysfunction patient. And we can intervene in ways to help with evaporation, because what is human meibum supposed to do? Human meibum helps with evaporation, it prevents evaporation, and it lowers surface tension. So those 2 things are both vitally important to the front surface. And when you have a supply and demand issue because you're staring at a screen 10, 12, 15 hours a day, your body cannot make up enough tears if your evaporation rates are too high. What is osmolarity measuring? Evaporation rates. That's all it measures. And so that point of care test can be very helpful in patient populations, so you know how much evaporation you really have, and where we are in the spectrum of dry eye disease. Again, that specific symptom profile, do we have comorbidities? And then what are the kind of drops are we utilizing to, maybe harmful the front surface? So exacerbation, preservative exposure, whether it's over-the-counter drops, whether it's cleansers, whether it's, things people are doing to remove makeup, whether it's putting makeup on, we have a whole, lecture on that. You guys have probably heard about or seen, or I know you all have patients like that are doing things inadvertently without knowing that it's harmful to the front surface. And tear film instability, of course, causes us to lose homeostasis, which leads to inflammation. And now we have symptom progression, and now we're in that vicious cycle of this is the chronic progressive disease. Patients have to understand that. When we look at compliance challenges, burning and stinging, and preservative-induced ocular discomfort, that's why patients that have glaucoma really struggle. It's because their eyes feel bad, and no matter what they put in, it doesn't feel good. And so they're going to stop doing anything. That's the challenge with that patient type. Their vision fluctuates. How frustrating. You're trying to read a book, you're trying to drive. Insufficient counseling. They don't know what they don't know. It seems like it's over the counter, therefore it's safe. We all know that is not true. And so there's opportunities here to talk to patients. Glaucoma is a lifelong condition that either requires a daily topical medication or some kind of interventional glaucoma treatment. And that preservative exposure can cause all kinds of issues long term. And again, we're talking about preservatives because we need to think about this for the long term of the patient. We've well established this. I think it's really interesting that we have this well established in cataract and refractive surgery. I mean, we've been doing this for 15 or 20 years where we only utilize preservative-free drops around cataract surgery, whether it's going into cataract surgery, during cataract surgery, and like immediately after, and then post-op. And I think it's interesting that we have ascribed to that methodology for our cataract and refractive surgery patients, but we haven't taken that to all of our patients. And I think that there's a lot of good information there that we should apply to the rest of our patient population. It's just taking that same information and giving that to the rest of our patients who are utilizing therapeutic medications or over-the-counter medications either way. And again, we're looking at corneal staining, gland dysfunction, tear film assessment. And of course, that tear film assessment here shows that tear meniscus height inferior, but you can do vital dye and be able to ascertain that without having to have some kind of special equipment. That's what I love about dry eye disease. And when you get really passionate about it, you only need the tools you already have. You need your mindset, the knowledge that you have. You need your slit lamp, which is what you guys all have every day, and vital dye. You've got your digits to push on meibomian glands, and you can download a questionnaire that's completely free, or you can ask the questions yourself. Doesn't require anything beyond that as far as equipment. So we just have to be proactive and thinking about this differently, because like we talked about earlier, those economic impacts, the cost of therapy to our patients. I think that there's a misconception that preservative-free options may be higher. When we think about productivity, we talked about that already. But when you're creating a whole nother disease state because of the choices that patients are making, there are economic impacts to that. So when we look about, going back to B8K for a minute, just thinking about why it does what it does, the mechanism, it's a microbicidal detergent that disrupts cell membranes. And again, we need good preservatives to protect any kind of water-based drop, right? Because we don't want to have microbes that grow in the bottle. We don't want to have fungus. When you look at this common range, 0.004% to 0.02% in ophthalmic solutions, any of those ranges can actually cause toxicity, and it can cause toxicity within a week. It penetrates and accumulates in ocular tissues over time. The other big gap that happens is BAK is also found in a lot of other things, including makeup removers. And one of the most common ones is a patient beloved makeup remover that is in a wipe that's actually in a package. Anytime you have a package with moist towelettes that are packed in there all together, you're going to have a hefty amount of preservative to keep things from growing in that dark package for the 30 days that patients are going to use it. So interestingly, one of those is BAK, and it's about 1,000 times concentration than what we see here that's in ophthalmic solutions. And we know that that causes toxicity over long term. So I'm very careful about prescribing patients things to take off their makeup with and asking that very simple question. If they like those kinds of wipes, just make sure they're individually packed and they don't have a ton of preservatives in them. So that's just a really easy one that patients unknowingly accidentally do. And we've already talked about all the things there because BAK, it causes trabecular damage as well and tear film disruption. So all the things that we need to know. Neurotoxicity of preservatives can cause corneal nerve exposure over time because it decreases that corneal nerve plexus. Oxidative stress, when we look at any kind of stress, whether it's UV exposure, smoking, preservatives, it induces mitochondrial dysfunction because you've got reactive oxygen species. And once you have that, then you have to have antioxidants to offset that. That's exactly why we utilize antioxidants with an AMD patient, because you have reactive oxygen species. That's why you use sunscreen so that you prevent those ROSs from forming. And then axonal degeneration, nerve fiber damage reduces that corneal sensation and blink response. And now you have a neurotrophic cornea. And now we've gone down another path. Impact on contact lens wear, when you have a lot of preservatives in contact lens solutions, that can stay with the lens and certainly on the front surface of the eye. It can cause ocular irritation. And now you have preservative residue that live underneath that lens. You get more tear film instability. And so now we can go down another path, even with our contact lens patients. And so I'm really careful about the solutions that we choose. And then also with a contact lens patient, really assessing what's happening on the ocular surface, not just assuming that it's the solution or the contact lens modality and switching to that. So we need to take the whole patient into account. Multiple preservatives, that's going to cause more problems. So think of the glaucoma patient who's on one medication and now needs a second one. That's big. And then we have, if you add anything to that and, artificial tear that's in a bottle that has an aggressive preservative, there's 3 things now, on the front. So those are just all things that we need to think about, taking that whole patient into account. And then, of course, our specialty cases like a patient with Sjogren's who is already aqueous deficient, extra careful corneal transplants, and then neurotrophic keratitis because it can perpetuate and continue that degenerative corneal condition where the corneal nerves continue to degrade. When we think about kiddos, long-term treatment, what's that doing to the ocular surface? We've already talked about the perioperative period. This is where we bought in really well on preservative-free. I want to expand that into the rest of our patient population. And there's lots of alternative preservatives, again, that aren't quite as harsh as BAK. And overcoming barriers, habits and inertia, changing human behavior is no easy task. It's quite difficult. And so that's why I like talking about this, because once we understand the why, it can make us ask questions of why are we doing things that we did in 1940 when we have different technologies available to us today to manage our patients in a different way? Why are we letting third party make these choices for us? We have to be the patient's advocate and work with our companies to make sure that the patients are getting what they need to get. There's this perceived cost that preservative-free options may be more expensive or they don't actually work as well. And we have lots of data and lots of studies that completely disagree with that, especially in glaucoma. So benefits of early intervention, we can certainly, when I can get to a dry eye patient when they're stage 1 versus stage 4, right? What would happen to that patient if I could have gotten them at stage 1? Nobody starts at stage 4. There's a point where they started. What happens if we intervene at a younger and younger and younger age? This was a paper that I did with a lot of my intrepid, brilliant minds. And we sat down and we looked at, okay, when would we try to find something that's preservative free? And so this was our questions and our decision tree. Am I treating the patient for a chronic disease? No. Is the patient using drops on a daily basis? No. Okay, great. Then that can be in a bottle and it can have a preservative, not as concerned. Patient using drops on a daily basis? Yes. Is it acute perioperative? Yes. Then preservative free should be on board. Over-the-counter lifestyle drops. Like if I want to lift up my eyelid, if I want a whitening drop, should we consider preservative free in those patients? Then looking at, am I treating the patient for a chronic disease? Yes. And so I love this decision tree. Just helps us with that decision making as we go through with our patients. And so we published this last December. So this is a good just resource. When we think about desiccating stress, and this came from TFOS Deuce 2, the one that was published in 2017, looking at all the ways that you can enter the vicious cycle. And that's what the gray scale is on the outside. That's all desiccating stress. When we think about what the definition of dry eye is, it's when the ocular surface structures fail to protect itself from desiccating stress. I'm going to say it one more time. When the ocular surface structures fail to protect itself from desiccating stress, that's when we have a problem. And it could be blepharitis, meibomian gland dysfunction. It could be topical drugs and preservatives. It can be allergies, all of those things. Now we have tear film instability. Now we have hyperosmolarity. Now we get apoptosis, inflammation, goblet cell loss, and the vicious cycle continues. Chronic and progressive. So when we think about our targeted treatments, and we're going to spend the last part of this talking about targeted treatments and what we have that's novel now, that's different. I like to think about all of the different categories. So I like to start on the outside and look at lids first, because that's certainly a comorbidity. We're looking for microbial changes, whether it is Demodex blepharitis or anterior blepharitis that is staph caused. That picture that you guys see is Demodex blepharitis because you see collarettes. Now we have a democidal with lotilaner 0.25%, BID for 6 weeks. And that's the before and after that you see. Those targeted treatments are a recipe for us to manage patients in a very different way. Lid hygiene is always part of my visual hygiene when I talk to patients. Here's how to you should wash your eyelids, right? When was the last time that you went to the dentist and you did not walk out with an instruction sheet of how to brush your teeth twice a day and how to floss at least once a day? No one leaves the dentist without that information. But when was the last time that your patients left your clinic with an instruction on how many times are you washing your eyelids and how are you doing that? It's a gap that we can easily fill. Debridement, antibiotics. So those are all ways that we can manage microbial changes and parasites on the eyelid margin. Evaporation. We now have the first and only dry eye treatment for evaporation and perfluorohexyloctane. It's 100% perfluorohexyloctane. There's no water in it, meaning it's completely preservative free. We'll talk more about that because that is new. Lacrimal filler. So that's another and different way to prevent evaporation, because you're putting a lacrimal filler into the lacrimal system so that tears can't drain. It has hyaluronic acid in it, so we get the benefits of that. Punctal plugs, and then we have OTC lubricants. Hyperosmolarity, inflammation, apoptosis. So you'll notice that all of these things are coming from this cycle. Tear film instability and imbalance because of evaporation, tear cell hyperosmolarity, and then we get over to the circle of inflammation. So that's where I get these categories from: microbial changes, evaporation, hyperosmolarity, inflammation, and then we get decreased meibum because that's coming in that very top circle where it says MGD, flora changes, eyelid inflammation, lipid changes. That's where all these categories came from. So when you have inflammation, we have steroids. I utilize steroids on a short-term basis, but I always want an exit strategy. We have lifitegrast, which is a very specific targeted anti-inflammatory for T cells, the activated T cells and inactivated T cells. So it affects both of those. We have cyclosporin, and we have 3 different formulations of cyclosporin to manage inflammation. Omega supplementation, that's part of my visual hygiene. Every patient should be on some type of omega supplementation unless they have, they've got other medications that would interfere or cause too much blood thinning. Neurostimulation is certainly a different way to manage inflammation and give a patient their own real tears. Serum tears, amniotic membranes, all of those things are under that category. And then looking at decreased meibomian gland dysfunction, and we want to increase flow. When you have a patient just like mine there, who I did heat and expression on, we're pushing all of that old junk out. There's nothing I can do until I get rid of that obstruction. We can do that with heat and expression. We can manage ocular rosacea with IPL. If we have fibrosis, we can do gland probing. So those are all targeted ways to treat. So I'm going to take just the ones that are new and novel for us and just expand on those a little bit more with our last few minutes here. Microbial changes. So we have a lid paradigm shift. That upper left picture is how I used to look at every single patient. I can't see what's happening at the base of the lash. Look at what I would have missed. And I like utilizing 16x on my mag, because when I have that patient look down, I can see a lot of collarettes on 10x, but I can see it even better on 16x. 25x, I'm kind of missing the forest for the trees. I lose some of my ability to see what's happening with their erythema, with their telangiectasias. So 16 is my Goldilocks, my magic number there. But that lid paradigm shift of having your patient simply look down has been massive, because it's a comorbidity that affects the ocular surface. And there's a before and after of one of my patients with lotilaner 0.25%. That was actually at 4 weeks. I leave the patient on it for a full 6 weeks, because remember, the mite cycle, their life cycle is about 16 to 18 days, which is why you utilize it for 2 weeks, because you got to get all of the ectoparasites that are alive and all of the eggs as well. So that's the first paradigm shift that came from that column, right? Microbial changes. The second shift in what's new and novel is targeting evaporation in a very different way with perfluorohexyloctane. And I like this graph. There's a lot going on here, but it's important when we think about what's happening on that left side. We have all of these 7,000 nerve endings. They have little tiny thermoreceptors that are constantly activated. They're cold thermoreceptors, TRP8 receptors that are constantly activated, so that we are keeping that tear film flush on the front surface, because we have that mucin cell layer that the goblet cells make, so everything sticks to where it's supposed to be. We have the aqueous layer that has all the 2,000 different components, whether it is chemokines, active cytokines, all of those things. And then we have that tiny thin layer of lipid on the top to prevent evaporation. And remember what we said, lower surface tension. When we lose that top layer, now we expose everything and we get disrupted tears. Now we have hyperosmolarity. We have activation of T cells, and now we recruit more T cells. Then the corneal nerves start to become overly sensitive. We have pain. The patient experiences that, and then we get nerve degeneration. And now we're on the path of a neurotrophic cornea. Or we're on the path of those sensitized nerves are so overstimulated that we have a neuropathic cornea, and it's overly done. The patient's in an enormous amount of pain, but they look pretty normal. So when we think about how to manage patients and looking at it, evaporation, like here's a perfect example. We've been talking about digital uses all night. Key points: case of a 27-year-old, eye strain. My eyes are tired at the end of the day. Multifaceted approach. I want to talk about the environment. I'm going to talk about taking breaks. But what else can I do when their supply and demand is so high? I can prevent evaporation, and I can do that with a preservative-free drop. So this is a perfect patient that we could use perfluorohexyloctane in. Remember how this works. We have a 14 hydrocarbon back chain, and there's 6 fluorines. So this belongs to what we call a semi-fluorinated alkane category of medication. And those 6 fluorines are highly aerophilic, meaning they want to be oriented towards the air. That's what it loves, right? And then you have those 8 saturated hydrocarbons that are lipophilic, that are going to want to be in the tear film. And that is what we say is an amphiphilic molecule, meaning it wants to be two places at once. And that's why it organizes itself so beautifully on the front surface. It's fascinating how this does this. So when we look at it, and this is just a demonstration of where it sits, and this was actually a study that looked at the oxygen carrying capability. So it's not really relevant for this conversation, but I like this diagram because we're able to protect that tear film and help the human meibum do its job better because we're creating that new air-tear interface because of the way that perfluorohexyl octane organizes itself with the air on top and the 8 saturated hydrocarbons buried in the tear film. That's why it organizes itself, and it just bobs along on the front surface, and it sits there for up to 6 hours. So when we have perfluorohexyl octane to help us with evaporation, that's a novel way to manage in a very different way, something that we've never been able to manage in that way before. And it's preservative free because it's 100% perfluorohexyl octane. Ocular sparing in the lacrimal functional unit. What happens if we stimulate the trigeminal nerve through the anterior ethmoidal nerve inside the nose, and we stimulate the entire lacrimal functional unit? Because when we do that, we stimulate all of the meibomian glands, all of the lacrimal gland and its accessory glands, and the goblet cells. So we're able to do that through the LFU, and we can do that through the nose. That therapeutic, whether it's mechanical or we're using varenicline through a nose spray, also both preservative free, and it's ocular sparing. We're not putting anything else on the front surface. And this is how it works, because when you're going from the LFU to the CNS, all of those afferent signals are coming typically from the cornea, but we can do that through the nose because of that branch of the trigeminal nerve that's coming through that anterior ethmoidal nerve that lives inside the nose. And then efferently, that's how we're getting, again, all of the lacrimal gland and the accessory glands, the meibomian glands, and the goblet cells. So a different way to manage preservative-free ocular sparing. And then we can also talk about interventional dry eye. And this was that 4th category that you saw coming from the TFOS DUCE 2. So interventional dry eye, we're talking about IPL, we're talking about heat and expression, radiofrequency, gland probing. This is a new and different way to think about this. We've been talking about interventional glaucoma for lots of years, whether we're doing SLT, whether we're doing a type of MIGS procedure, whether we're doing combined cataract and something in the operating room to help with pressure. Those are all interventional glaucoma therapies. Now we have interventional dry eye therapies that we can also utilize. I love IPL for managing ocular rosacea, for managing patients that have meibomian gland disease with ocular rosacea. Heat and expression we have to do if we have obstruction. Radiofrequency helps to rebuild collagen so it has a tighter blink reflex. It has heat involved. We're increasing blood flow. And then gland probing is exactly what it says. We're opening those fibrotic meibomian glands so that they can flow again. So lots of different ways. And when we think about cases like this, this is a glaucoma patient. He's at risk of having that preservative-induced dry eye disease. SLT is first-line therapy. You can use SLT. You can utilize a drop. We have prostaglandins even that are preservative-free. So it's just thinking in a different way before we just reach for what we've always been taught to do, and thinking about, okay, maybe we do one drop, but what about when we add a second one? Certainly, we need to give patients more options. And think about preservative-free formulations, helping prevent evaporation in that patient population, doing, interventional dry eye therapies or interventional glaucoma therapies. If you've got a patient with a contact lens patient, decrease in lens comfort, despite wearing the latest technology, you have to look at the ocular surface and their tear film function before you start just switching lenses and switching solutions. That's the last resort. You got to look at the ocular surface first, see what's happening there before you jump right to that. And then, addressing digital eye strain in young professionals, because they're, again, supply and demand, they just cannot keep up. And I have so many patients that ask how their eyes feel at the end of the day. And they're like, man, my eyes are tired. they are dry, they are gritty. And I love the question, when do your eyes feel the worst, morning or evening? Because that's very much going to drive how I manage the patient. If it's first thing in the morning, then we have a lid seal problem. We may have lag ophthalmos. We have something going on at night that I'm going to manage with an ointment and with moisture chamber goggles in a different way. But if it's getting worse as the day goes, that's an evaporation issue. And so that's why it's so important for us to just have that comprehensive evaluation. It doesn't have to be hard or overly complicated. It just helps us target and mitigate some of this impact that our patients are having to do day to day, including ourselves. So in summation, the mindset is so important. Adopting this proactive, patient-centric approach to ocular surface health, understanding that it's a multifactorial disease, and now we have different ways that we can personalize those treatment plans. And it comes from us diagnosing that paradigm shift of having the patient look down, looking at their tear breakup time to evaluate how fast their tears evaporate, looking at their tear meniscus height. Do they make enough tears? Pushing on their meibomian glands to see, do they have enough meibum to support that front surface? And now we can treat with very targeted therapies based on what we find in that diagnosis, which in turn empowers our patients to take better care of themselves, have a better quality of life long term. And then, we have such a high, I love what I do because I get to help these people. And so it just has a high quality of life, even for me, not just for the patients.